Welcome back, students, to another exciting explainer. I'm thrilled to be acting as your lead instructor today. We are officially on part 59 of our IPDRG masterclass. And let me tell you, today we're tackling a subject that is absolutely foundational to everything we've covered so far. We're diving deep into unspecified codes, clinical documentation integrity, and effective physician query strategies. Honestly, grab your notebooks, because this session is going to completely change how you look at a medical record. But before we really get into the weeds, I do want to quickly mention, if you're enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal. Your support means everything, and it's what allows us to keep bringing you this masterclass level education. Okay, here's our game plan for today's syllabus. First, a quick intro and recap. Second, we'll dig into the very real risks of unspecified codes. Third, we'll break down the CDI framework. Fourth, we'll talk about how to write compliant physician queries. And finally, we'll wrap up with a summary and a teaser for next time.
Let's kick things off with Section 1, our intro and recap, just to ground our knowledge before we push forward.
As healthcare professionals, we know these complex concepts just constantly build on one another, right? So let's make sure our foundation from our last session is rock solid. Remember in Part 58, we thoroughly covered the Inpatient Prospective Payment System, or IPPS, payment formula. We learned exactly how DRG's relative weight reflects the actual resource intensity of a patient's stay and how those cost outliers can shift the final hospital reimbursement. You should already be pretty comfortable with the fact that higher documented severity equals a higher relative weight and therefore proper payment for the resources consumed.
Moving right along to Section 2, the risks of unspecified codes. And guys, this is literally the villain of the revenue cycle.
With our baseline established, let's talk about the absolute #1 threat we face on a daily basis when it comes to protecting a hospital's financial integrity. Think about it. Vague documentation completely forces a coder's hand. If a provider just scribbles heart failure, well, a coder cannot legally just assume they meant acute on chronic systolic heart failure. They have to default to the unspecified code. And what does that do? It leads directly to undercoding. By using that vague, unspecified terminology, the hospital suffers a base DRG downgrade and loses out on critical complication or major complication, CC or MC status. Ultimately, the code just doesn't reflect how sick the patient in the bed actually was.
Let's put some real-world perspective on this. Let's say a patient is admitted for pneumonia. If the coder misses a secondary diagnosis of COPD simply because it wasn't documented clearly by the physician, the claim just defaults to simple pneumonia without CC. Based on our source data, that single missing detail drops the expected reimbursement from roughly $8,500 way down to $6,200. That is a direct revenue loss of $2,300 on a single claim, just because of a lack of specificity.
So to prevent this kind of massive financial exposure, we absolutely have to master the core specificity dimensions. As coders and auditors, we're basically hunting for 4 main things. First, anatomical laterality. Is that fracture on the left, right, or bilateral femur? Second, acuity. Is this respiratory failure acute, chronic, or acute on chronic? Third, underlying etiology. Can we establish a clear cause and effect linkage, like a diabetic foot ulcer with osteomyelitis? And fourth, manifestation and disease staging. These are the exact details that transform a weak, unspecified code into an accurate, high-severity code.
And listen, let me be very clear here. This is not just a best practice, it's a strict mandate. CMS and commercial payers have built aggressive claims editing systems that automatically hunt down and reject high-risk, unspecified diagnoses. If you're relying on vague terminology, your claim won't just get paid a little less. It's going to get stalled, completely denied, or flagged for a grueling, stressful medical record audit.
All right, let's look at Section 3, the CDI framework. This is the bridge between clinical care and coding. So how do we actually fix this massive problem? We can't just guess what the doctor meant, right? Enter CDI, Clinical Documentation Integrity. This is the vital bridge between the actual clinical care happening on the floor and the final coding that ends up on the bill. A CDI specialist isn't just skimming notes. They are deeply analyzing clinical indicators. They're looking at abnormal lab values, diagnostic imaging results, vital signs, and medication administration records to make absolutely sure the physician's written word perfectly matches the reality of the patient's severity of illness and risk of mortality. Here's how this translates into a really strict operational workflow. It always starts with documentation review, which is often done concurrently while the patient is actually still in the hospital. Now, when a CDI specialist spots a gap,
Let's say they see a high creatinine lab, but there's no corresponding kidney diagnosis. That creates what we call a query trigger. The specialist then formally and legally asks the clinician for clarification. We get the clinician response, and finally, the coding update is made. By aggressively hunting for this kind of clinical evidence in the chart, CDI specialists capture the hospital's true case mix index, or CMI. Remember, your CMI is basically the average of all your DRG weights. It literally proves how complex the hospital's patients actually are. By unearthing those hidden CCs and MCCs, like spotting the lab values for hyponatremia or acute kidney injury, or recognizing the dietary consults for protein-calorie malnutrition, CDI permanently prevents DRG undercoding.
Now for Section 4, Compliant Physician Queries. Let's talk about applying the rules.
This is where things get incredibly tricky. How do we actually ask the doctors for this missing specificity legally without crossing the line into fraud? Well, the rules here are extremely strict, and they're governed by official bodies like AHIMA and ACDIS. The absolute golden rule is that your queries must never, ever be leading. You cannot suggest a specific monetary or coding outcome to a physician. If you do, you're opening the hospital up to devastating audits under the False Claims Act for unethical upcoding. Every single query you write has to be objectively clinically supported by what is already sitting there in the medical record. Check out the stark difference between a leading and a non-leading query. An illegal leading query sounds like this. Do you agree the patient has septic shock, which is an MCC? That is blatantly telling the doctor how to code for money. No way. Now look at the compliant version. You provide the clinical indicator first, reviewing lactate 4.0, and then you ask them to clarify the current status, offering all clinically reasonable choices: septic shock, severe sepsis, sepsis without organ failure, or other. See the difference? To stay totally compliant, you really should stick to one of 3 query formats. Multiple choice is your gold standard when you have several supported diagnosis options. Yes/no is strictly regulated. You should only use it to clarify a diagnosis that is already partially documented. And open-ended queries? Those are best when multiple clinical solutions are possible and you just can't provide a neat little list for the physician.
Knowing these formats helps, but you also need to know where to spend your time. Focus your CDI and coding efforts on these high-yield scenarios. First, conflicting documentation, like when the attending physician writes sepsis, but the infectious disease consultant writes SARS. You have to clear that up. Second, establishing causal relationships, getting the doctor to link phrases like due to or secondary to between chronic kidney disease and hypertension. And third, pinning down clinical acuity, getting the provider to explicitly define if that encephalopathy is acute, chronic, or maybe both.
Finally, Section 5, Summary and Teaser. Let's go ahead and wrap up Part 59.
We have covered a tremendous amount of ground today, dealing with some of the absolute most sensitive and financially impactful rules in inpatient coding. So let's recap. Our main takeaways. Number 1, unspecified codes are a massive risk that will trigger immediate revenue loss and payer denials. Number 2, a strong CDI workflow is your best defense, beautifully bridging the gap between clinical indicators and coding to capture your hospital's true case mix index. And number 3, if you have to query a physician, it must strictly adhere to non-leading compliance logic to avoid upcoding fraud. Understanding these rules perfectly sets the stage for our next lesson. In Part 60, we are going to look at what happens when things go wrong. We'll be tackling IPDRG coding audits, denial management, and the step-by-step process for reconsideration appeals when the payer flat-out rejects your claim. You definitely won't want to miss it. Class is dismissed for today, but I want to leave you with this provocative thought. Are the medical records you're looking at telling the full, true story of that patient or just the unspecified cliff notes? Think about that before our next session. And remember, if you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal. See you next time, students.